The adrenal glands. Q&A document. Welcome to today's podcast, where we discuss the surgical management of diseases of the adrenal gland. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of diseases of the adrenal gland. Pause the podcast after each question to attempt answer. Let's begin. History question. Who first described the adrenal glands and how were they originally named? Answer. Italian anatomist Bartolomeo Eustachi first described the adrenal glands in 1564 as glands lying on the kidney. Question. Who identified the distinct structural parts of the adrenal gland? Answer. German anatomist Albert von Kuliker identified the two distinct parts of the adrenal gland, the cortex and the medulla. Question. When were adrenal hormones first isolated, and what milestones were achieved in this process? Answer. Adrenaline was first isolated around the year 1900, and steroid hormones were crystallized from cortical extract in the 1930s. Question. What challenges were encountered in isolating steroid hormones from the adrenal glands? Answer. The highly similar chemical structures of steroid hormones made isolating individual compounds difficult. Question. Who described the clinical features of primary adrenal failure and when? Answer. Thomas Addison described the clinical features of primary adrenal failure in 1855. Question. Who received the Nobel Prize in Physiology or Medicine in 1950 for work related to adrenocortical hormones? Answer. Edward Kendall, Thaddeus Reichstein, and Philip Hench received the Nobel Prize in Physiology or Medicine in 1950 for their work on adrenocortical hormones. Question. Who first described the stress response in mammals and contributed to the understanding of the hypothalamic pituitary adrenal axis? Answer. Hans Selye first described the stress response in mammals in 1936 and contributed to the understanding of the hypothalamic pituitary adrenal axis. Question. Who were awarded the Nobel Prize in Physiology or Medicine in 1977 for their contributions to adrenal gland research? Answer. Roger Guimau, Andrew Shelley, and Rosalind Yalow were awarded the Nobel Prize in Physiology or Medicine in 1977. Question. What achievement led to award recognition in adrenal gland research in the late 20th century? Answer. The characterization of peptide hormones in the brain that regulate the hypothalamic pituitary adrenal axis led to award recognition. Anatomy and embryology. General and developmental aspects. Question. Where are the adrenal glands located in the human body? Answer. The adrenal glands are positioned superior and slightly medial to the kidneys in the retroperitoneal space. Question. What is the typical appearance of the adrenal glands? Answer. The adrenal glands are flattened, roughly pyramidal or crescent-shaped, and have an orange or yellow color. Question. How is the blood supply to the adrenal glands characterized? Answer. The adrenal glands are highly perfused organs, receiving 2,000 milliliters per kilogram per minute of blood. Question. What is the embryonic origin of the adrenal cortex and medulla? Answer. The cortex originates from coalomic mesodermal tissue, while the medulla arises from ectodermal tissues of the embryonic neural crest. Question. At what stage does the adrenal cortex become dominant during fetal development, and how does the medulla develop? Answer. The cortex becomes dominant at 4 months of fetal development, while the medulla develops in parallel with the sympathetic nervous system, starting in the 5th to 6th week of gestation. Question. What are the primary cellular components of the adrenal cortex and medulla? Answer. The cortex is primarily composed of cortical cells, while the medulla consists of chromaffin cells. Question. How can embryologic development affect surgical outcomes related to the adrenal glands? Answer. Embryologic development can lead to surgically relevant sequelae, such as the presence of cortical and medullary tissue at extraadrenal sites. Question. What are extraadrenal pheochromocytomas and where can they arise? Answer. Pheochromocytomas, also known as paragangliomas when extraadrenal, can arise in a wider range of locations than previously thought. Question. How common are extraadrenal sites for chromaffin tissue compared to cortical tissue? Answer. Extraadrenal sites for chromaffin tissue are more common than for cortical tissue. Relationships. Question. Where is the right adrenal gland located relative to other organs? Answer. The right adrenal gland is located posterior to the liver, inferior to the right kidney, and adjacent to the vena cava. Question. Where is the left adrenal gland situated? Answer. The left adrenal gland is situated between the left kidney and the aorta, with its inferior portion extending towards the renal hilum. Question. How are the adrenal glands enveloped in relation to the kidneys? Answer. Each adrenal gland is surrounded by its own capsule and shares Gerota's fascia with the kidneys. Vasculature. Question. What arteries supply blood to the adrenal glands? Answer. The adrenal glands receive diffuse arterial supply from the superior adrenal arteries, from inferior phrenic arteries, middle adrenal arteries, from juxtaceliac aorta, and inferior adrenal arteries, from renal arteries. Question. How is venous drainage of the adrenal glands typically organized? Answer. There is usually solitary venous drainage for each adrenal gland. Question. Into which vein does the left adrenal vein drain? Answer. The left adrenal vein drains into the left renal vein after joining the inferior phrenic vein. Question. Where does the right adrenal vein drain? Answer. The right adrenal vein drains directly into the vena cava or into an accessory right hepatic vein. Question. What is notable about the size of the right adrenal vein? Answer. The right adrenal vein is typically as short as it is wide, measuring about half a centimeter. Question. What surgical challenge is presented by the right adrenal vein during adrenalectomy? Answer. The short length and direct drainage of the right adrenal vein into the vena cava present a surgical challenge during right adrenalectomy. Normal histopathology. Question. How thick is the adrenal cortex and what portion of the gland's mass does it comprise? Answer. The adrenal cortex is approximately 2 mm thick and comprises more than 80% of the gland's mass. Question. What are the characteristics of the zona glomerulosa in the adrenal cortex? Answer. The zona glomerulosa is the outer layer of small cells with moderately eosinophilic, lipid-poor cytoplasm, forming an undulating inner border. Question. What distinguishes the zona fasciculata within the adrenal cortex? Answer. The zona fasciculata is composed of long radial columns of large, clear, lipid-laden cells, constituting most of the adrenal cortex. Question. How is the adrenal medulla structurally composed? Answer. The adrenal medulla is composed of clusters and short cords of chromaffin cells, which are large, polyhedral, and packed with basophilic secretory granules. Question. What are the characteristics of chromaffin cells in the adrenal medulla? Answer. Chromaffin cells contain catecholamines that yield a brown reaction when treated with chromium salts. Question. How is the adrenal medulla connected to the nervous system? Answer. The adrenal medulla medulla is richly endowed with autonomic nerve fibers and ganglion cells, with sympathetic fibers synapsing directly with chromaffin cells. Question: how does the microvasculature of the adrenal gland enhance the stress response? Answer: the adrenal gland's microvasculature unifies the cortex and medulla in a portal system configuration to enhance the stress response. Question: what is the pathway of blood flow through the adrenal gland? Answer: arteries form a subcapsular plexus. Blood flows through the cortex, and then enters the medulla. Question: what drives phenylethanolamine and methyltransferase expression in the adrenal medulla and what is its function? Answer: phenylethanolamine and methyltransferase expression is driven by cortisol in the medulla and is responsible for converting norepinephrine to epinephrine. Biochemistry and physiology. Adrenal steroid biosynthesis. Question: how does adrenal steroid biosynthesis begin in the adrenal gland? Answer: adrenal steroid biosynthesis begins with cholesterol transport to the inner mitochondrial membrane by the steroidogenic acute regulatory protein. Question: how is cholesterol converted during steroid hormone synthesis? Answer: cholesterol undergoes oxidative reactions, primarily catalyzed by cytochrome P450 enzymes, to produce pregnenolone. Question: how are sex steroids produced in the adrenal gland? Answer: pregnenolone and progesterone are converted into dehydroepiandrosterone and androstenedione by cytochrome P450-17. Question: where are additional sex hormones such as testosterone, estrone, and estradiol synthesized? Answer: additional enzymatic steps in the gonads generate testosterone, estrone, and estradiol from androstenedione. Question: how is cortisol synthesized in the adrenal gland? Answer: cortisol is produced by oxidation of 17-hydroxypregnenolone by 3-beta-hydroxysteroid dehydrogenase, followed by cytochrome P450-21A2 and cytochrome P450-11B1. Question: how is aldosterone generated in the adrenal gland? Answer: aldosterone is produced by oxidation of corticosterone by cytochrome P450-11B2 in the zona glomerulosa. Steroid hormone physiology and metabolism. Question: what are the characteristics of steroid hormones? Answer: steroid hormones are low molecular weight, lipophilic signaling molecules that bind to intracellular receptors, leading to delayed and prolonged gene expression changes. Question: what are some examples of steroid hormones? Answer: examples of steroid hormones include thyroid hormone, retinoids, vitamin D, and endogenous steroid hormones. Question: how are steroid hormones metabolized and excreted from the body? Answer: steroid hormones are primarily metabolized in the liver through hydroxylation, sulfonation, or conjugation to glucuronic acid, followed by urinary excretion. Glucocorticoids. Question: what triggers the release of corticotropin-releasing factor and what is its effect? Answer: the release of corticotropin-releasing factor triggers adrenocorticotropic hormone secretion from the anterior pituitary. Question: how does adrenocorticotropic hormone stimulate glucocorticoid secretion? Answer: adrenocorticotropic hormone stimulates glucocorticoid secretion from the adrenal cortex by binding to G-protein coupled receptors. Question: what is the secretion pattern of adrenocorticotropic hormone? Answer: adrenocorticotropic hormone secretion is pulsatile and circadian, with peak levels in the morning and lowest levels in the evening. Question: how do glucocorticoids affect blood glucose levels? Answer: glucocorticoids increase blood glucose by stimulating gluconeogenesis and inhibiting glucose uptake in peripheral tissues. Question: what impact do glucocorticoids have on lipid and protein metabolism? Answer: glucocorticoids promote lipolysis, releasing free fatty acids, and induce insulin resistance, leading to protein catabolism. Question: what serves as energy sources and substrates for gluconeogenesis during glucocorticoid activity? Answer: fatty acids and amino acids, released from lipolysis and protein catabolism, serve as energy sources and substrates for gluconeogenesis. Question: how do glucocorticoids influence the cardiovascular system? Answer: glucocorticoids enhance catecholamine signaling, increasing cardiac contractility and peripheral vascular tone. Question: what is the mechanism by which glucocorticoids affect arterial smooth muscle cells? Answer: glucocorticoids sensitize arterial smooth muscle cells to beta-adrenergic stimulation and increase catecholamine concentrations in neuromuscular junctions. Question: how can glucocorticoid administration treat adrenal insufficiency? Answer: glucocorticoid administration can remedy hemodynamic collapse by restoring cardiovascular function. Question: what are the anti-inflammatory effects of glucocorticoids? Answer: glucocorticoids reduce circulating lymphocyte and eosinophil counts, increase neutrophil counts, and suppress histamine release. Question: how do glucocorticoids exert immunosuppressive effects? Answer: glucocorticoids promote lymphocyte apoptosis and decrease cytokine and immunoglobulin production. Question: how do glucocorticoids inhibit prostaglandin synthesis? Answer: glucocorticoids reduce prostaglandin synthesis by inhibiting phospholipase A2. Mineralocorticoids. Question: what primarily regulates aldosterone release in the adrenal gland? Answer: aldosterone release is primarily regulated by angiotensin II and blood potassium levels. Question: how does the renin-angiotensin-aldosterone axis respond to sodium delivery in the kidney? Answer: the renin-angiotensin-aldosterone axis responds to sodium delivery to the distal convoluted tubule, with low sodium delivery stimulating aldosterone release. Question: how do potassium levels affect aldosterone release? Answer: hypokalemia reduces aldosterone release, while hyperkalemia increases it. Question: what is the function of aldosterone in fluid and electrolyte regulation? Answer: aldosterone regulates fluid volume and electrolyte balance by promoting sodium and chloride retention. Question: what effect does aldosterone have on extracellular fluid volume and blood pressure? Answer: aldosterone expands extracellular fluid volume and increases blood pressure. Question: how is aldosterone feedback regulated in the kidney? Answer: Aldosterone feedback is suppressed by increased sodium delivery to the distal tubule, reducing renin release. Adrenal sex steroids question. How is adrenal androgen secretion regulated, and which androgen is produced in the smallest quantity? Answer. Adrenal androgen secretion is regulated by adrenocorticotropic hormone and other mechanisms, with androstenedione produced in the smallest quantities. Question. How do adrenal sex steroids compare in physiological effect to gonadal sex steroids, especially in males? Answer. Adrenal sex steroids are generally weaker than gonadal sex steroids, particularly in males. Question. What role do adrenal androgens play in females? Answer. Peripheral conversion of dehydroepiandrosterone and dehydroepiandrosterone sulfate to more potent androgens supports pubic and axillary hair growth, and may influence libido and well-being. Catecholamine biosynthesis and physiology question. Where does catecholamine synthesis primarily occur in the adrenal gland? Answer. Catecholamine synthesis occurs in the adrenal medulla. Question. What is the rate-limiting step in catecholamine synthesis? Answer. The rate-limiting step is the hydroxylation of tyrosine to L-dopa. Question. How is dopamine converted to norepinephrine in catecholamine biosynthesis? Answer. Dopamine is converted to norepinephrine through beta-hydroxylation. Question. Where is epinephrine synthesized within the body? Answer. Epinephrine is synthesized in the chromaffin cells of the adrenal medulla and the organ of Zucker-Kendall. Question. Which enzyme is responsible for the synthesis of epinephrine? Answer. Phenylphenolamine and methyltransferase is responsible for the synthesis of epinephrine. Question. What triggers the release of catecholamines from the adrenal medulla? Answer. Sympathetic stimulation triggers the release of catecholamines, norepinephrine and epinephrine, from the adrenal medulla. Question. How does stress affect catecholamine release from the adrenal medulla? Answer. While basal levels are low, stressors can increase catecholamine secretion up to 50-fold. Question. How do norepinephrine and epinephrine interact with adrenergic receptors? Answer. Norepinephrine binds more strongly to alpha-adrenergic receptors, while epinephrine binds more strongly to beta-adrenergic receptors. Question. What are the effects of beta-2 and alpha-1 adrenergic receptor activation? Answer. Beta-2 adrenergic receptors cause smooth muscle relaxation, while alpha-1 adrenergic receptors cause vasoconstriction. Question. Where are alpha-2 adrenergic receptors located and what is their function? Answer. Alpha-2 adrenergic receptors are located presynaptically in the central nervous system and attenuate sympathetic outflow. Question. What is the effect of adrenal catecholamine release on blood flow and oxygen delivery? Answer. Adrenal catecholamine release increases blood flow and oxygen delivery to the brain, heart, and skeletal muscle, supporting the fight-or-flight response but at the cost of other organ systems. Catecholamine clearance question. What are the characteristics of catecholamines regarding their potency and duration of action? Answer. Catecholamines are potent, short-acting compounds with a plasma half-life of about 1 minute. Question. How is catecholamine activity regulated in the body? Answer. Catecholamine activity is tightly regulated by reuptake and degradation. Question. Which pathways are responsible for the degradation of catecholamines? Answer. Catecholamines are inactivated by monoamine oxidase and catechol-O-methyltransferase, producing metabolites used in Pheochromocytoma evaluation. Question. What are the primary metabolites of catecholamines? Answer. The primary metabolites of catecholamines are metanephrine, normetanephrine, and vanillyl mandelic acid. Question. Why are metanephrine and normetanephrine useful as diagnostic markers? Answer. Metanephrine and normetanephrine are stable in plasma, making them useful diagnostic markers. Question. How are catecholamine metabolites excreted from the body? Answer. Catecholamine metabolites are excreted in urine, often after undergoing sulfonation or glucuronidation in the liver. Adrenal insufficiency. Types of adrenal insufficiency. Primary adrenal insufficiency. Addison disease. Question. What is Addison's disease? Answer. Addison's disease is a rare condition characterized by weakness, fatigue, loss of appetite, nausea or vomiting, weight loss, darkening of the skin, low blood pressure, and disturbances in electrolytes. Question. What causes hyperpigmentation in Addison's disease? Answer. Hyperpigmentation is now believed to result from adrenocorticotropic hormone-induced stimulation of melanin production in skin cells. Question. How was Addison's disease originally described? Answer. Addison's disease was originally described in patients who had destruction of the adrenal glands due to tuberculosis. Question. What are the main causes of hormonal insufficiency in primary adrenal insufficiency? Answer. Hormonal insufficiency is caused by problems such as congenital adrenal gland underdevelopment, defects in steroid hormone production, and destruction of the adrenal gland. Question. What are the common causes of adrenal gland destruction in primary adrenal insufficiency? Answer. Autoimmune destruction is the most common cause, followed by infections of the adrenal gland, spread of cancer to the gland, and bleeding into the gland. Question. What is Waterhouse-Friderichsen syndrome? Answer. Waterhouse-Friderichsen syndrome is adrenal gland bleeding caused by severe infection, seen more commonly in children and people without a spleen. Secondary adrenal insufficiency question. What is secondary adrenal insufficiency? Answer. Secondary adrenal insufficiency is a relatively common disorder caused by a deficiency of adrenocorticotropic hormone. Question. What is a common cause of secondary adrenal insufficiency? Answer. It often occurs when someone stops taking steroid medication, especially after high doses or using it for a long period. Question. What factors affect the rate of recovery of the hypothalamic pituitary adrenal axis after steroid withdrawal? Answer. The recovery rate depends on how long and how severely glucocorticoids were used in the past. Question. What are some less common causes of secondary adrenal insufficiency? Answer. Less frequent causes include loss of all pituitary function due to tumor or infiltration, granulomatous disease, and bleeding or death of pituitary tissue. Question. When can pituitary infarction occur? Answer. Pituitary infarction may occur after severe bleeding following childbirth, known as Cushing syndrome. Adrenal insufficiency in the critically ill question. How does hypothalamic pituitary adrenal axis dysfunction manifest in critically ill patients? Answer. In critical illness, especially with sepsis or a systemic inflammatory response, patients may develop an acute and reversible decrease in hypothalamic pituitary adrenal axis function. Question. What is the incidence of hypothalamic pituitary adrenal axis dysfunction in critically ill patients? Answer. This disorder occurs in approximately 30% of critically ill patients and may be even more common in those with septic shock. Question. What mechanisms are proposed for hypothalamic pituitary adrenal adrenal axis dysfunction in critical illness? Answer. Possible mechanisms include resistance of the adrenal gland to adrenocorticotropic hormone and reduced sensitivity of target tissues to glucocorticoids. Question. What are the benefits of corticosteroid treatment in critically ill patients? Answer. Corticosteroids have been shown to slightly lower 30-day mortality and lead to faster reversal of shock. Question. How does corticosteroid dosage affect outcomes in critically ill patients? Answer. Physiologic. Normal doses may be helpful, but high doses can be harmful. Question. What are some side effects of corticosteroid use? Answer. Side effects include high blood sodium levels, high blood sugar, and weakness of the muscles. Question. What have earlier clinical trials suggested about glucocorticoid use in septic shock? Answer. Earlier trials suggested that patients with severe septic shock, especially those needing medication to raise blood pressure, might benefit from glucocorticoids. Question. What do recent data say about the survival benefit of corticosteroids in critically ill patients? Answer. Recent studies have not confirmed a significant survival benefit, so corticosteroid use should be individualized for each patient. Question. What is the recommended dosage range and duration for glucocorticoid treatment in critically ill patients? Answer. Glucocorticoids are typically given for 5 to 7 days at a dose up to 300 mg per day or less of hydrocortisone, or a similar drug. Adrenal crisis. Question. What is an adrenal crisis? Answer. An adrenal crisis is a life-threatening condition that happens when someone with low adrenal function faces a major sudden physical stress. Question. What are the main causes of adrenal crisis? Answer. Adrenal crisis is typically triggered by severe acute stress such as infection or injury, or by sudden and complete loss of adrenal function. Question. What symptoms are seen in adrenal crisis? Answer. Symptoms include shock, abdominal pain, fever, nausea and vomiting, changes in electrolytes, and sometimes low blood sugar. Question. What is the primary pathogenic mechanism in adrenal crisis? Answer. The main mechanism is a lack of mineralocorticoids, leading to problems maintaining sodium and blood volume. Question. What is the secondary pathogenic mechanism in adrenal crisis? Answer. A second mechanism is decreased cardiovascular response to catecholamines due to lack of glucocorticoids. Question. Should treatment for suspected adrenal crisis be delayed for diagnostic testing? Answer. Treatment for suspected adrenal crisis should not be postponed while waiting for diagnostic tests. Question. What is the focus of adrenal crisis treatment? Answer. Treatment should focus on rapid intravenous infusion of large volumes of isotonic saline solution. Question. What are the recommended glucocorticoid regimens for adrenal crisis? Answer. Hydrocortisone, 100 mg intravenously as a bolus, then 75 mg every 8 hours, or dexamethasone, 4 mg intravenously every 24 hours, can be used. Question. What is the advantage of dexamethasone in adrenal crisis? Answer. Dexamethasone is long-acting and does not interfere with laboratory tests of the body's own glucocorticoid production. Question. Is early mineralocorticoid replacement a priority in adrenal crisis treatment? Answer. Early mineralocorticoid replacement is not a priority because its effects are not immediate and fluid and electrolyte balance can be restored with saline infusion. Diagnosis and treatment. Diagnosis. Question. How is adrenal insufficiency diagnosed? Answer. Diagnosis of adrenal insufficiency depends on recognizing symptoms and performing laboratory tests. Question. In which clinical settings is adrenal insufficiency often seen? Answer. It is often seen in intensive care units, trauma, or surgical settings, especially in patients with chronic illnesses requiring steroids. Question. How is the diagnosis of adrenal insufficiency confirmed? Answer. Confirmation requires both routine and stimulation laboratory tests. Question. How is cortisol production assessed in suspected adrenal insufficiency? Answer. Cortisol production is measured using morning blood or saliva samples. Question. What morning cortisol levels generally exclude adrenal insufficiency? Answer. A blood cortisol above 15 mg per deciliter or a saliva cortisol above 5.8 nanograms per milliliter usually rules out adrenal insufficiency. Question. When is provocative testing necessary for adrenal insufficiency diagnosis? Answer. Provocative stimulation testing is needed for patients whose cortisol levels are below the normal range. Question. How is the cosintropin stimulation test performed for adrenal insufficiency? Answer. Cosintropin, 250 micrograms, is injected and blood cortisol is measured 30 to 60 minutes later. Question. What is considered a positive result for adrenal insufficiency in cosintropin stimulation testing? Answer. A stimulated blood cortisol level less than 18 mg per deciliter indicates adrenal insufficiency. Question. How is the type of adrenal insufficiency determined after biochemical confirmation? Answer. Once adrenal insufficiency is confirmed, a morning adrenocorticotropic hormone level is measured to distinguish between primary and secondary forms. Treatment. Question. How is an adrenal crisis treated? Answer. Treatment involves replacing normal levels of glucocorticoids and mineralocorticoids. Question. What is the recommended glucocorticoid replacement regimen for adrenal insufficiency? Answer. Hydrocortisone is usually given as 20 mg in the morning and 10 mg in the evening. Question. What is the recommended mineralocorticoid replacement for adrenal insufficiency? Answer. Fludrocortisone is given at a dose of 0.1 mg each day. Question. What is the approach to steroid administration during surgery in patients with adrenal insufficiency? Answer. Recommendations for steroid use during surgery are based on uncontrolled retrospective studies, and the need for high doses is often overestimated. Question. Why are patients with Addison's disease at higher risk for perioperative adrenal crisis? Answer. Patients with Addison's disease cannot increase cortisol production in response to stress, making them more susceptible to adrenal crisis during surgery. Question. What is the hydrocortisone requirement for patients with Addison's disease undergoing surgery? Answer. Such patients typically need 100 mg of hydrocortisone intravenously before anesthesia is started. Question. Are patients with secondary adrenal insufficiency at high risk of perioperative crisis? Answer. Patients with secondary adrenal insufficiency from chronic steroid use have a low risk, 1 to 2%, of a low blood pressure crisis if not given extra steroids during surgery. Question. How should glucocorticoid therapy be managed in chronic users during the perioperative period? Answer. People who use steroids chronically likely should continue their usual dose during the surgical period to prevent low blood pressure crisis. Question: when is glucocorticoid supplementation recommended for patients undergoing unilateral adrenalectomy? Answer: supplemental glucocorticoids are recommended only for those with Cushing syndrome or mild autonomous cortisol production. Diseases of the adrenal cortex. Primary aldosteronism. Epidemiology and clinical features. Question: what is the definition of primary aldosteronism? Answer: primary aldosteronism is the uncontrolled release of excessive aldosterone from one or both adrenal glands. Question: what symptoms are commonly associated with primary aldosteronism? Answer: the common symptoms are persistent hypertension and low potassium levels, although many patients may have normal potassium levels. Question: what is the estimated prevalence of primary aldosteronism among patients with hypertension? Answer: primary aldosteronism is generally believed to affect around 1% of patients with hypertension. Question: what is the actual prevalence of primary aldosteronism in unselected hypertensive patients? Answer: the actual prevalence is likely 7% or lower, contrary to earlier reports of 10 to 40% that were affected by referral bias. Question: how does non-selective use of the aldosterone to renin ratio screening affect the detection of surgically correctable primary aldosteronism? Answer: non-selective use of this ratio reduces the proportion of patients with primary aldosteronism that can be treated surgically. Question: what is the impact of non-selective screening on surgically treatable cases of primary aldosteronism? Answer: although the absolute number of surgically treatable cases increases, the fraction of these cases among all screened patients decreases. Question: what are the typical demographics of patients diagnosed with primary aldosteronism? Answer: the average age at diagnosis is 50 years, with a slight predominance among males. Question: how do most patients with primary aldosteronism present clinically? Answer: most patients are asymptomatic, but some may experience muscle cramps, weakness, or abnormal sensations caused by low potassium levels. Question: what are the characteristics of hypertension in primary aldosteronism? Answer: hypertension is usually moderate to severe, resistant to medical treatment, and often requires multiple medications to control. Question: what is the overall impact of primary aldosteronism on patient health? Answer: primary aldosteronism is linked with a substantially increased risk of stroke, heart attack, abnormal heart rhythms, and heart failure. Question: how does the cardiovascular risk from primary aldosteronism compare with risk from elevated blood pressure alone? Answer: the harmful cardiovascular effects of primary aldosteronism are more significant than those caused by high blood pressure alone. Question: what is the expected outcome following surgical correction of primary aldosteronism? Answer: surgical correction leads to reversal of many negative physiological changes associated with the disease. Question: what are the most common causes of primary aldosteronism? Answer: the most frequent causes are single aldosterone-producing tumors and bilateral enlargement of the adrenal glands. Question: how has the prevalence of aldosterone-producing tumors changed with the use of the aldosterone to renin ratio screening? Answer: the prevalence has decreased, probably due to increased detection of bilateral adrenal gland enlargement. Question: what genetic mutations are commonly found in aldosterone-producing tumors? Answer: genetic mutations are found in 94% of these tumors and affect ion channels and the enzyme adenosine triphosphatase. Diagnosis and localization. Question: what is the first step in diagnosing primary aldosteronism? Answer: the first step is a biochemical diagnosis. Question: what is the primary goal of diagnosis in patients suspected of having primary aldosteronism? Answer: the goal is to identify patients with primary aldosteronism and distinguish between different subtypes for the best management. Question: which patients should be screened for primary aldosteronism using biochemical tests? Answer: screening is recommended for patients with hypertension and unexplained low potassium, hypertension and an adrenal gland nodule, hypertension and sleep apnea, early onset hypertension, and hypertension resistant to treatment. Question: how is the diagnosis of primary aldosteronism confirmed? Answer: it is confirmed by measuring the ratio of aldosterone concentration in the blood to the activity of renin in the blood. Question: how should the aldosterone to renin ratio test be performed for optimal accuracy? Answer: the test is most accurate after stopping medications that could interfere with the results. Question: what are the typical cutoff values used for the aldosterone to renin ratio, and what are their implications? Answer: cutoff values vary, with 30 being common and offering about 90% sensitivity. A cutoff of 20 increases sensitivity but decreases specificity. Question: why is it important to diagnose surgically correctable hyperaldosteronism? Answer: missing the diagnosis is clinically significant because surgical treatment can reverse the condition. Question: how can the specificity of aldosterone to renin ratio screening be increased? Answer: including an absolute aldosterone concentration higher than 15 mg per deciliter increases the specificity of the initial screening. Question: what additional screening is recommended for young patients testing positive for primary aldosteronism? Answer: patients younger than 30 years old should be genetically screened for glucocorticoid remediable aldosteronism. Question: what is glucocorticoid remediable aldosteronism? Answer: it is a rare inherited condition in which aldosterone production is abnormally regulated by adrenocorticotropic hormone and is treatable with medication. Question: what is the goal of confirmatory biochemical testing in primary aldosteronism? Answer: the goal is to show that aldosterone levels are inappropriately high. Question: what methods are used for confirmatory testing in primary aldosteronism? Answer: methods include intravenous saline loading or oral salt loading, followed by measuring aldosterone levels. Question: what is the role of fludrocortisone in oral salt loading tests? Answer: fludrocortisone is used in some centers to increase specificity, but it is not widely adopted. Question: what is the purpose of subtype differentiation in primary aldosteronism? Answer: the purpose is to distinguish between different causes of the disease to select the best treatment. Question: what methods are used to differentiate subtypes of primary aldosteronism? Answer: subtypes are differentiated using sampling of adrenal veins, anatomical imaging, and sometimes functional scanning. Question: what is the typical size of an aldosterone-producing tumor? Answer: most of these tumors are smaller than 15 mm in their largest dimension. Question: why is adrenal vein sampling important before surgical management of primary aldosteronism? Answer: adrenal vein sampling helps to accurately locate the source of excessive aldosterone before surgery. Question: what is considered the gold standard for differentiating differentiating subtypes of primary aldosteronism? Answer. Adrenal vein sampling is the gold standard for subtype differentiation. Question. How is adrenal vein sampling performed? Answer. It involves simultaneous measurement of cortisol and aldosterone levels in the blood from the peripheral circulation and from the adrenal veins. Question. How is the result of adrenal vein sampling interpreted? Answer. A cortisol concentration more than 3 times higher in the adrenal vein compared to peripheral blood indicates successful sampling. A 4-fold higher ratio of aldosterone to cortisol on one side points to the affected gland. Question. When should adrenal vein sampling be performed in patients with primary aldosteronism? Answer. It should be performed in all patients with confirmed primary aldosteronism and no abnormalities or bilateral abnormalities on detailed adrenal imaging. Question. Is there controversy regarding adrenal vein sampling in patients with a unilateral adrenal mass on imaging? Answer. Yes. There is significant debate about which patients with a unilateral adrenal mass should undergo adrenal vein sampling. Question. What is a possible outcome after unilateral adrenalectomy in patients with a unilateral adrenal mass on imaging? Answer. Some patients may have continued excessive aldosterone production after surgery, indicating a non-functioning tumor and a different diagnosis. Question. How should adrenal vein sampling be applied in older patients? Answer. More liberal use of adrenal vein sampling is advised for patients aged 40 years and older. Question. How is adrenal vein sampling used in young patients with adrenal masses? Answer. Young patients with a unilateral adrenal mass greater than 1 centimeter and a normal opposite adrenal gland can proceed directly to surgery. Question. What is recommended for young patients without clear localization of an adrenal mass on imaging? Answer. These patients should undergo adrenal vein sampling. Question. What proportion of patients being evaluated for primary aldosteronism undergo adrenal vein sampling? Answer. About 30 to 40% of patients undergo adrenal vein sampling. Question. What is the success rate of adrenal vein sampling? Answer. The success rate is low, ranging from 40 to 80%, often due to difficulty accessing the right adrenal vein. Question. What are the main limitations of adrenal vein sampling? Answer. Limitations include a low success rate, possible incomplete localization, and limited access to specialized centers. Surgical management and outcomes. Question. What is the preferred surgical procedure for managing aldosterone-producing tumors and most adrenal tumors? Answer. Minimally invasive removal of the adrenal gland is the preferred procedure. Question. How is cure of primary aldosteronism defined? Answer. Cure is defined by reductions in blood pressure, the need for blood pressure medications, aldosterone levels in blood and urine, and correction of low potassium levels. Question. What are the cure rates for primary aldosteronism at specialty centers? Answer. Cure rates range from 75% to 95% at specialized centers. Question. What is the overall rate of treatment success for primary aldosteronism? Answer. Over 80% of patients achieve either normal blood pressure or a significant reduction in medication use. Question. How is treatment success defined after surgery for primary aldosteronism? Answer. Complete success is normal blood pressure without medication. Partial success is lower blood pressure or reduced medication. No success means no improvement. Question. How is biochemical success defined after surgery? Answer. Complete success is normal potassium and a normal aldosterone to renin ratio. Partial success is normal potassium and a 50% reduction in aldosterone. No success means no biochemical improvement. Question. How should medications be managed after surgery for primary aldosteronism? Answer. Mineralocorticoid antagonists, angiotensin-converting enzyme inhibitors, and angiotensin receptor blockers should be stopped immediately. Beta blockers and alpha blockers should be reduced gradually to avoid sudden effects. Question. What is the recommendation regarding calcium channel blockers after surgery? Answer. Calcium channel blockers may be continued at the discretion of the clinician. Question. How should hypertension be managed after adrenal surgery? Answer. Medications can be reintroduced temporarily if needed until blood pressure stabilizes. Question. What is the impact of hyperaldosteronism on kidney disease? Answer. Patients with hyperaldosteronism have a higher rate of chronic kidney disease compared to those with hypertension alone. Question. What effect can adrenalectomy have on kidney function? Answer. Removal of the adrenal gland may reveal the true extent of chronic kidney disease by lowering kidney filtration rates. Question. What is a possible complication after adrenalectomy in patients with hyperaldosteronism? Answer. Temporary high potassium levels may occur in 5 to 10% of patients, especially those with kidney problems or suppressed opposite adrenal glands. Question. Which patient subsets may experience reduced benefit from adrenal surgery? Answer. Patients over 45 years old, with a family history of hypertension, long-term hypertension, use of multiple medications, and those who do not respond to spironolactone may benefit less from surgery. Question. What are possible reasons for reduced benefit from adrenal surgery? Answer. These factors may indicate essential hypertension or irreversible heart and blood vessel changes caused by chronic disease. Question. What should patients be counseled about before adrenal surgery? Answer. Patients should be informed of the possible limitations of surgery in controlling their hypertension. Cushing Syndrome Epidemiology and Clinical Features. Question. What are the clinical features of Cushing Syndrome? Answer. Clinical features include fat accumulation around the organs and trunk, muscle weakness and wasting, resistance to insulin or type 2 diabetes, high blood pressure, abdominal stretch marks, rounded face, fat pad behind the neck, increased body hair, easy bruising, and thin skin. Question. What is the prognosis for untreated Cushing syndrome? Answer. Untreated Cushing syndrome can be fatal, with a 5-fold increase in mortality mainly due to heart and blood vessel complications. Question. What physiological derangements are common in Cushing syndrome? Answer. Common derangements are high blood pressure, high blood sugar, and fat accumulation around the trunk. Question. What is the primary treatment goal for Cushing syndrome? Answer. The goal is to identify and treat the underlying cause of excessive cortisol production. Question. What should be considered in the differential diagnosis of Cushing syndrome? Answer. Both causes related to adrenocorticotropic hormone and those not related to adrenocorticotropic hormone should be considered. Question. What is the most common cause of Cushing syndrome? Answer. The most common cause is the use of corticosteroid medications. Question. How common is endogenous Cushing syndrome? Answer. Endogenous Cushing syndrome is rare, affecting 5 to 10 people per million. Question. What are the main subtypes of endogenous Cushing syndrome? Answer. The main subtypes types are Cushing disease at 75%, primary adrenal Cushing syndrome at 15%, and ectopic adrenocorticotropic hormone syndrome at less than 10%. Biochemical diagnosis and localization question. How is Cushing syndrome diagnosed biochemically? Answer. Diagnosis is based on showing inappropriate cortisol secretion or loss of the normal feedback system. Question. What is the normal pattern of cortisol secretion? Answer. Cortisol normally follows a daily rhythm, peaking after waking and reaching its lowest level around midnight. Question. What are the standard diagnostic tests for Cushing syndrome? Answer. Tests include measuring cortisol in urine over 24 hours, late-night saliva cortisol, and the 1 mg overnight dexamethasone suppression test. Question. How is cortisol typically found in the blood? Answer. More than 90% of circulating cortisol is bound to proteins in the blood. Question. What forms the basis of biochemical screening for Cushing syndrome? Answer. Screening is based on assessing unbound cortisol in urine and saliva. Question. What is recommended for patients with moderately elevated 24-hour urine cortisol levels? Answer. They should have confirmatory testing with 2 late-night saliva cortisol measurements. ACTH-independent Cushing syndrome question. What is primary adrenal Cushing syndrome? Answer. It is also known as adrenocorticotropic hormone-independent Cushing syndrome and is caused by uncontrolled cortisol production from the adrenal glands. Question. What are the levels of adrenocorticotropic hormone in ACTH-independent Cushing syndrome? Answer. Levels of adrenocorticotropic hormone are usually undetectable because of feedback inhibition. Question. What are the underlying causes of ACTH-independent Cushing syndrome? Answer. Causes include single adrenal gland tumors, adrenal cancer, and bilateral small or large gland enlargement. ACTH-dependent Cushing syndrome question. What is ACTH-dependent hypercortisolism and its most common cause? Answer. It is caused by excessive adrenocorticotropic hormone, most often from a small pituitary gland tumor. Question. How is ACTH-dependent Cushing syndrome diagnosed? Answer. Diagnosis uses pituitary imaging and testing suppression with high doses of dexamethasone. Question. How is high-dose dexamethasone suppression testing performed? Answer. It involves measuring cortisol in blood or urine after giving 2 mg of dexamethasone every 6 hours for 48 hours. Question. Why is dexamethasone selected for suppression testing? Answer. Dexamethasone does not interfere with biochemical measurements of cortisol. Question. What is the typical response of corticotroph tumors to high-dose dexamethasone? Answer. High-dose dexamethasone usually suppresses these tumors, but not tumors that produce adrenocorticotropic hormone outside the pituitary. Question. When is pituitary surgery indicated in ACTH-dependent Cushing syndrome? Answer. If a pituitary mass larger than 6 mm is seen in a patient with ACTH-dependent Cushing syndrome suppressed by high-dose dexamethasone, pituitary surgery is recommended. Question. How is Cushing disease diagnosed? Answer. Diagnosis uses sampling of adrenocorticotropic hormone in the veins draining the pituitary with stimulation by corticotropin-releasing factor. Question. What does a central to peripheral gradient in adrenocorticotropic hormone indicate? Answer. It confirms the diagnosis of Cushing disease. Question. What is the approach when no clear gradient is found in adrenocorticotropic hormone sampling? Answer. Imaging of the chest and abdomen and sometimes scanning for somatostatin receptors are used to find the source of hormone production outside the pituitary. Surgical management and outcomes question. What is the role of glucocorticoid administration in Cushing syndrome? Answer. Glucocorticoids are essential for patients with Cushing syndrome, particularly during and after surgery. Question. What is the recommended stress dose steroid protocol for adrenal gland removal? Answer. 100 mg of hydrocortisone intravenously every 8 hours for 24 hours is recommended. Question. How are steroids managed following surgery for Cushing syndrome? Answer. Steroids are tapered to normal levels over weeks, but some patients may need supplementation for longer periods, sometimes more than a year. Question. What is the postoperative management of glucocorticoids? Answer. Glucocorticoids are initially withheld to assess remission, then resumed until the hypothalamic pituitary adrenal axis recovers, usually about 6 months. Question. How is early remission assessed after surgery for Cushing syndrome? Answer. A subnormal morning cortisol level on the first or second day after surgery indicates a cure. Question. Why should glucocorticoid management be coordinated with an endocrinologist? Answer. It should be managed with an experienced endocrinologist because of the risk of adrenal crisis. Question. How effective is adrenal gland removal in treating primary adrenal Cushing syndrome? Answer. It is more than 90% effective, but some physiological effects may persist. Question. What is the success rate of pituitary surgery for Cushing disease? Answer. Success rates approach 90% in skilled centers, with further surgery or radiation possible if the initial procedure fails. Question. What is the risk of thromboembolism in patients with Cushing syndrome after surgery? Answer. These patients are at increased risk for blood clots in the veins after surgery and require preventative treatment with blood-thinning medications. Special case. Mild autonomous cortisol secretion question. What is mild autonomous cortisol secretion? Answer. It is a term replacing subclinical Cushing syndrome, defined by adrenal masses found incidentally and biochemical evidence of excessive cortisol without obvious signs or symptoms. Question. How is mild autonomous cortisol secretion diagnosed? Answer. Diagnosis is based on a blood cortisol level above 50 nanomoles per liter after a 1 mg dexamethasone suppression test, without typical signs of cortisol excess. Question. What is known about the prognosis of mild autonomous cortisol secretion? Answer. The physiological consequences and natural progression of mild autonomous cortisol secretion are not fully understood. Question. What metabolic conditions are more prevalent in individuals with mild autonomous cortisol secretion? Answer. High blood pressure, abnormal cholesterol levels, and poor glucose tolerance are more common. Question. What are the benefits of surgical treatment for mild autonomous cortisol secretion? Answer. Surgery leads to improvements in obesity, blood pressure, blood sugar control, and cholesterol levels. Question. What did randomized controlled trials show about surgery for mild autonomous cortisol secretion? Answer. Trials showed that surgery resulted in more frequent resolution of high blood pressure and other metabolic problems compared to observation. Question. When is surgery recommended for mild autonomous cortisol secretion? Answer. Surgery is recommended for patients with mild atypical Cushing syndrome and related conditions conditions who are suitable candidates. Question. What tumor size considerations are important for surgery in mild autonomous cortisol secretion? Answer. Larger tumors, especially 3 to 4 centimeters, and those that grow on follow-up imaging are encouraged for surgery. Question. What is the benefit of restoring normal cortisol levels across the spectrum of Cushing syndrome severity? Answer. Patients benefit from normal cortisol levels regardless of how severe their Cushing syndrome is. Sex steroid excess. Question. What types of adrenal tumors cause excess sex steroid production? Answer. Most adrenal tumors causing excess sex steroid production are those that lead to masculine features, while tumors causing feminine features are almost always cancerous. Question. What is the likelihood of malignancy in virilizing adrenal tumors? Answer. About 1/3 of virilizing adrenal tumors are cancerous. Question. How common is virilization among adrenocortical carcinomas? Answer. 20% of adrenocortical carcinomas cause virilization, mainly in children, with nearly a quarter showing both Cushing syndrome and virilization. Question. How are virilizing adrenal tumors detected biochemically? Answer. Detection involves measuring testosterone, dehydroepiandrosterone, and dehydroepiandrosterone sulfate in urine collected over 24 hours. Question. What is the preferred treatment approach for most adrenal tumors? Answer. Minimally invasive removal of the adrenal gland is preferred. Question. When is open adrenal gland removal recommended? Answer. Open surgery is recommended for tumors with clear signs of cancer, such as local invasion or spread to other organs. Adrenocortical carcinoma. Question. What is the prevalence of adrenocortical carcinoma? Answer. It is a rare tumor with an annual incidence of approximately 1 per million people. Question. Is there a sex predilection for adrenocortical carcinoma? Answer. There is no significant difference in occurrence between sexes. Question. How do adrenocortical carcinomas typically present regarding size and spread? Answer. They are usually very large when diagnosed and have often spread beyond the adrenal gland. Question. What is the 5-year overall survival rate for adrenocortical carcinoma? Answer. Historically, the rate is 15 to 20%. Question. What is the 5-year survival rate after surgical removal of adrenocortical carcinoma? Answer. The rate is about 40% and has remained unchanged in the past 20 years. Question. What are risk factors for poor outcomes in adrenocortical carcinoma? Answer. Poor outcomes are associated with older age, poorly differentiated or aggressive tumors, positive surgical margins, and distant spread. Question. How many adrenocortical carcinomas are functional, and what is the most common function? Answer. More than half are functional, most commonly causing Cushing syndrome, followed by virilization. Question. What is the typical radiographic appearance of adrenocortical carcinoma on computed tomography? Answer. It appears as a heterogeneous mass with irregular or unclear borders, central destruction, and invasion of nearby structures. Question. What imaging is indicated for preoperative staging of adrenocortical carcinoma? Answer. A computed tomography scan of the chest is recommended. Question. What are common sites of metastatic disease in adrenocortical carcinoma? Answer. Metastases may be found in lymph nodes, liver, and lungs. Question. What additional imaging may be beneficial in suspected metastatic adrenocortical carcinoma? Answer. Positron emission tomography with fluorodeoxyglucose may be useful. Question. What is the primary treatment for adrenocortical carcinoma? Answer. Surgery is the only potentially curative treatment. Question. When is aggressive surgery indicated for adrenocortical carcinoma? Answer. Aggressive surgery is indicated for isolated tumors or disease limited to the region. Question. What are the outcomes for minimally invasive surgery in small adrenocortical carcinomas? Answer. For small stage 1 and stage 2 tumors, survival is similar for open and minimally invasive techniques when performed by experienced surgeons. Question. What is the standard treatment for large adrenocortical carcinomas? Answer. Radical removal, usually by open surgery, is standard. Question. What is the rate of complete surgical removal in adrenocortical carcinoma? Answer. Complete removal is possible in up to 70% of cases with experienced surgeons. Question. What special considerations apply to right-sided adrenocortical carcinoma? Answer. Right-sided tumors may extend into the main vein and heart, requiring possible use of heart-lung bypass during surgery. Question. What is the prognosis for patients with incomplete removal of adrenocortical carcinoma? Answer. These patients have very short survival, usually less than 1 year. Question. How common are recurrence and metastasis after successful surgery for adrenocortical carcinoma? Answer. Local recurrence and spread to other organs are common, usually within 2 years. Question. What is the role of midotane in treatment of adrenocortical carcinoma? Answer. Midotane, a medication derived from an insecticide, is the main chemotherapy used as additional treatment or for cases that cannot be removed or have spread. Question. What limits the use of midotane in adrenocortical carcinoma? Answer. Its use is limited by significant digestive and nervous system toxicity. Question. What were the results of the Pheochromocytoma trial in adrenocortical carcinoma? Answer. The combination of etoposide, doxorubicin, cisplatin, and midotane showed better response and progression-free survival compared to streptozotocin and midotane in advanced or metastatic disease. Question. What was the overall survival in the Pheochromocytoma trial for adrenocortical carcinoma? Answer. Median overall survival was poor in both groups, at about 15 and 12 months. Question. What targeted agents are being tested in clinical trials for adrenocortical carcinoma? Answer. These include inhibitors of epidermal growth factor, inhibitors of insulin-like growth factor, agents that block blood vessel growth, and broad-spectrum enzyme inhibitors. Question. What is the emerging therapeutic approach for adrenocortical carcinoma? Answer. Individualized therapy based on the genetic and expression profile of the tumor is an emerging approach. Diseases of the adrenal medulla. Pheochromocytoma. Epidemiology and clinical features. Question. Who published the first account of pheochromocytoma and when? Answer. The first account of pheochromocytoma was published in 1886 by Felix Frankl. Question. Why is pheochromocytoma named as such? Answer. Pheochromocytoma is named for the characteristic positive chromophene reaction of the tumors. Question. Who initially described successful surgical management of pheochromocytoma and in what years? Answer. Successful surgical management of pheochromocytoma was initially described in 1926 by Kaiser Wu and in 1927 by Charles Mayo. Question. What is the prevalence and demographic distribution of pheochromocytoma among hypertensive individuals? Answer. Pheochromocytoma affects 0.2% 90% of hypertensive individuals, equally impacting males and females, with peak incidence between 40 and 50 years old in sporadic cases. Question: what are the classic symptoms of pheochromocytoma and how common is hypertension in affected patients? Answer: the classic triad of symptoms includes headache, diaphoresis, and palpitations, with hypertension present in 90% of cases. Question: why is the diagnosis of pheochromocytoma challenging? Answer: diagnosis is challenging due to nonspecific symptoms and the prevalence of essential hypertension, with only 0.5% of symptomatic hypertensive patients actually having pheochromocytoma. Question: what conditions should be considered in the differential diagnosis of pheochromocytoma? Answer: the differential diagnosis is broad, including hyperthyroidism, hypoglycemia, coronary artery disease, heart failure, stroke, drug-related effects, and panic disorder. Question: why is pheochromocytoma clinically significant? Answer: pheochromocytoma is clinically significant due to potentially lethal cardiovascular effects caused by bioactive compounds secreted by the tumors, necessitating aggressive screening and treatment. Question: what are silent pheochromocytomas and how are they diagnosed? Answer: silent pheochromocytomas are incidentally discovered and minimally secreting, requiring a high clinical index of suspicion for diagnosis. Question: what impact have genetic discoveries had on the understanding of pheochromocytoma? Answer: genetic discoveries have challenged previous assumptions about pheochromocytoma. Question: what were the old axioms regarding pheochromocytoma occurrence? Answer: the old axioms were that 10% are bilateral, 10% are malignant, 10% are extraadrenal, and 10% are familial. Question: what is special about pheochromocytoma in pregnancy? Answer: pheochromocytoma in pregnancy is a special case. Question: how does pheochromocytoma affect pregnancy outcomes? Answer: pheochromocytoma in pregnancy is rare but potentially fatal for mother and child, with a 12% fetal mortality rate if diagnosed antenatally. Question: what are the outcomes associated with unrecognized pheochromocytoma in pregnancy? Answer: unrecognized pheochromocytoma significantly increases maternal and fetal complications. Question: what is the recommended treatment for pregnant patients with pheochromocytoma? Answer: alpha blockade is recommended for all pregnant patients with pheochromocytoma, with adrenalectomy considered in the second trimester if diagnosed before 24 weeks. Biochemical diagnosis and localization. Question: how is the biochemical diagnosis of pheochromocytoma established? Answer: the biochemical diagnosis is based on detecting elevated catecholamines and their metabolites in body fluids. Question: what is the traditional method for diagnosing pheochromocytoma biochemically? Answer: the traditional method is measuring 24-hour urine levels of catecholamines and their metabolites. Question: what is the currently recommended test for pheochromocytoma and what is its sensitivity? Answer: plasma-free metanephrine testing is currently recommended due to its high sensitivity, approaching 99%. Question: what is the specificity of plasma-free metanephrine testing for pheochromocytoma? Answer: the specificity of plasma-free metanephrine testing is at best 89%, with most laboratories likely in the 85% range or below. Question: what is a major problem with plasma-free metanephrine testing in screening for pheochromocytoma? Answer: a major problem is false positives due to the rarity of pheochromocytoma compared to the large pool of hypertensive individuals being screened. Question: what is the estimated false positive to true positive ratio when using plasma-free metanephrine testing as a screening tool for pheochromocytoma? Answer: the false positive to true positive ratio is estimated to be as high as 30:1 with plasma-free metanephrine testing as a principal screening tool. Question: what is the primary usefulness of plasma-free metanephrine testing in the evaluation of pheochromocytoma? Answer: the primary usefulness is excluding pheochromocytoma when the test result is negative. Question: what confirmatory testing is recommended when plasma-free metanephrine testing is positive for pheochromocytoma? Answer: when the test result is positive, confirmatory testing using 24-hour urine levels of catecholamines and their metabolites is recommended. Question: what drugs and conditions can lead to false positive results in biochemical testing for pheochromocytoma? Answer: many drugs and conditions, including sympathomimetics, phenoxybenzamine, acetaminophen, psychotropic drugs, and major physical or psychological stressors, can lead to false positive results. Question: how are catecholamine test cutoff values established for pheochromocytoma diagnosis? Answer: catecholamine test cutoff values are set high to maximize specificity, approximately double the upper 95% reference range. Question: what constitutes a positive urine test for pheochromocytoma? Answer: a positive urine test is defined by total metanephrenes or any single catecholamine fraction above the cutoff value. Question: what is the sensitivity of the urine test for pheochromocytoma? Answer: the urine test has an acceptable sensitivity of 88%. Question: what is a key characteristic of pheochromocytomas regarding catecholamines? Answer: pheochromocytomas synthesize and metabolize catecholamines. Question: how do tumor secretory profiles vary among pheochromocytomas? Answer: tumors may have heterogeneous secretory profiles based on the relative expression of synthetic and degradative enzymes. Question: how is the diagnosis of pheochromocytoma confirmed in most cases? Answer: 24-hour urine collections for catecholamines and their metabolites are sufficient for diagnosis in almost all cases. Question: when might the clonidine suppression test be used in pheochromocytoma evaluation? Answer: the clonidine suppression test may help clarify equivocal test results but is rarely used. Question: what imaging modalities can be used for anatomic localization of pheochromocytoma? Answer: magnetic resonance imaging or computed tomography scans can be used for anatomic localization. Question: which imaging modality provides better anatomical detail for surgical planning in pheochromocytoma, and how does its sensitivity compare to magnetic resonance imaging? Answer: computed tomography often provides better anatomical detail for surgical planning than magnetic resonance imaging, despite magnetic resonance imaging's slightly higher sensitivity. Question: what is the specificity of computed tomography and magnetic resonance imaging in diagnosing pheochromocytoma, and why? Answer: both computed tomography and magnetic resonance imaging have a specificity of only 70% due to the common occurrence of incidental adrenal nodules. Question: what is the role and sensitivity of mid-iodobenzylguanidine scanning in pheochromocytoma? Answer. Mid-iodopin zilguanidine scanning is highly specific but less sensitive, with a sensitivity of 77 to 90%, and is used when multifocal or malignant disease is suspected. Question. Which positron emission tomography or computed tomography radiopharmaceutical has the highest lesion detection rate for pheochromocytoma? Answer. Gallium-68. It has the highest lesion detection rate of 97.6% for pheochromocytoma. Question. Which novel radionuclides are more sensitive than mid-iodopin zilguanidine for imaging pheochromocytoma? Answer. Fluorine 18-dihydroxyphenylalanine and fluorine 18-dopamine are more sensitive than mid-iodopin zilguanidine for pheochromocytoma imaging. Question. Where are advanced positron emission tomography or computed tomography techniques for pheochromocytoma primarily available? Answer. Advanced positron emission tomography or computed tomography techniques are primarily available at select academic centers globally. Surgical management and outcomes. Question. Why is close communication between the surgeon and anesthesiologist important during pheochromocytoma surgery? Answer. Close communication between the surgeon and anesthesiologist is crucial for successful pheochromocytoma surgery. Question. What are the essential components of anesthetic management during pheochromocytoma surgery? Answer. Invasive hemodynamic monitoring, meticulous fluid management, and preparation for administering supplemental medications are essential. Question. Why is minimizing tumor manipulation important during the surgical procedure? Answer. Minimizing tumor manipulation is important during the surgical procedure. Question. What is the success rate of surgery as a treatment for pheochromocytoma? Answer. Surgery is curative in over 90% of pheochromocytoma cases. Question. Can most pheochromocytomas be removed using minimally invasive approaches? Answer. Most pheochromocytomas can be removed successfully with a minimally invasive approach. Question. When is open resection recommended in pheochromocytoma surgery? Answer. Open resection is recommended for larger tumors, greater than or equal to 6 centimeters, to prevent tumor rupture and potential recurrence. Question. How have advancements in surgical technique impacted outcomes in pheochromocytoma surgery? Answer. Advancements in surgical technique have reduced operative complication rates. Question. What has replaced traditional exploration methods in pheochromocytoma surgery? Answer. Image-guided exploration has replaced traditional exploration methods. Question. What is the outcome of using image-guided exploration in pheochromocytoma surgery? Answer. Image-guided exploration has resulted in diminished rates of solid organ injury. Molecular genetics of pheochromocytoma. Question. How common are familial pheochromocytomas? Answer. Familial pheochromocytomas are more common than previously thought. Question. Which syndromes are associated with pheochromocytomas? Answer. Multiple endocrine neoplasia type 2, von Hippel-Lindau syndrome, and neurofibromatosis type 1 are syndromes associated with pheochromocytoma. Question. What are the penetrance rates of pheochromocytoma in associated syndromes? Answer. Multiple endocrine neoplasia type 2 has a penetrance rate of 40 to 50%, von Hippel-Lindau syndrome has a penetrance rate of 10 to 20%, and neurofibromatosis type 1 has a penetrance rate of 1 to 5%. Question. What is the function of the succinate dehydrogenase protein complex? Answer. Succinate dehydrogenase is a mitochondrial protein complex that catalyzes essential steps in oxidative phosphorylation. Question. How are hereditary pheochromocytoma and paraganglioma associated with genetics? Answer. Germline mutations in the genes encoding succinate dehydrogenase subunits are causatively associated with hereditary pheochromocytoma and paraganglioma. Question. What is the structure of the succinate dehydrogenase protein complex? Answer. Succinate dehydrogenase is composed of 4 subunits and 2 co-assembly units. Question. Who should receive germline genetic testing for pheochromocytoma and paraganglioma? Answer. Germline genetic testing is indicated for all patients with pheochromocytoma and paraganglioma. Question. What proportion of pheochromocytoma patients have a germline mutation? Answer. At least 1/3 of pheochromocytoma patients have a germline mutation. Question. How can discovering a germline mutation in pheochromocytoma influence patient management? Answer. Discovering a germline mutation can influence prognosis, surveillance, prompt further investigations, and enable early identification of affected family members. Question. What are the clinical implications for patients with SDHB mutations? Answer. SDHB mutation carriers have high rates of extraadrenal pheochromocytomas and malignant disease. Question. How do patients with SDHD mutations typically present? Answer. Patients with SDHD mutations tend to present with multiple tumors and hormonally inactive paragangliomas of the head and neck. Question. What is the estimated lifetime penetrance of pheochromocytoma or paraganglioma in succinate dehydrogenase mutations? Answer. The lifetime penetrance of pheochromocytoma or paraganglioma in succinate dehydrogenase mutations is estimated at more than 75%. Question. What surgical approach is recommended for familial pheochromocytoma with high risk of contralateral disease? Answer. Cortical-sparing adrenalectomy is recommended for familial pheochromocytoma cases with a high risk of contralateral pheochromocytoma. Question. How much adrenal tissue should be preserved to maintain adequate cortical function? Answer. At least 1/3 of one adrenal gland should be preserved to maintain adequate cortical function. Question. What is the benefit of preserving adrenal tissue during surgery? Answer. Preserving adrenal tissue eliminates the need for exogenous steroids. Metastatic pheochromocytoma. Question. What is the rate of metastasis in pheochromocytoma? Answer. 2.5% to 40% of pheochromocytomas metastasize depending on the genotype. Question. What is the 5-year survival rate in patients with metastatic pheochromocytoma? Answer. The 5-year survival rate ranges from 20% to 45% in patients with metastatic pheochromocytoma. Question. How is metastasis defined in pheochromocytoma? Answer. Metastasis is defined as the presence of pheochromocytoma in non-chromaffin-derived tissues. Question. What are the common sites of metastasis in pheochromocytoma? Answer. The axial skeleton, lymph nodes, liver, lung, and kidney are the common sites of metastasis for pheochromocytoma. Question. What is the primary focus of treatment in patients with metastatic pheochromocytoma? Answer. The treatment focuses on surgical resection for primary and recurrent disease, even if a cure is not possible, for palliative benefits. Question. What therapies are available for metastatic pheochromocytoma? Answer. Iodine 131 mid-iodopin zilguanidine radionuclide therapy and lutetium-177 dodasomatostatin analog are potential treatments, but no targeted therapies are currently available. Question: how should catecholamine XS be managed in metastatic pheochromocytoma? Answer: chronic medical management should involve alpha-1 adrenergic selective blockers. Question: how do metastatic pheochromocytomas respond to traditional treatments such as radiotherapy and chemotherapy? Answer: metastatic pheochromocytomas are minimally responsive to radiotherapy and conventional chemotherapy. Other adrenal diseases incidentally discovered adrenal mass. Incidentaloma. Epidemiology and differential diagnosis. Question: what are adrenal incidentalomas? Answer: adrenal incidentalomas are adrenal masses discovered incidentally during imaging performed for unrelated conditions. Question: how prevalent are adrenal incidentalomas? Answer: adrenal incidentalomas are found in up to 8% of autopsies and 4% of abdominal imaging studies, with prevalence increasing to 10% in patients over 60 years of age. Question: when did adrenal incidentalomas become recognized as a clinical entity? Answer: adrenal incidentalomas became recognized as a clinical entity with the increased use of computed tomography and magnetic resonance imaging scans in the 1980s. Question: what is included in the differential diagnosis of adrenal incidentalomas? Answer: the differential diagnosis of adrenal incidentalomas is broad, including both secreting and non-secreting neoplasms. Question: what is the most likely cause of an adrenal mass in patients with a history of malignancy? Answer: in patients with a history of malignancy, the most likely cause of an adrenal mass is metastatic disease. Question: what is the most likely cause of an adrenal mass in patients without a history of malignancy? Answer: in patients without a history of malignancy, the most likely cause of an adrenal mass is a non-functioning cortical adenoma or another benign lesion. Clinical evaluation and surgical management. Question: how are adrenal incidentalomas evaluated? Answer: adrenal incidentalomas are evaluated using hormonal evaluation and size criteria. Question: where are the principles and methods for hormonal evaluation discussed? Answer: the principles and methods for hormonal evaluation are discussed in two more specific sections. Question: is hormonal evaluation generally applicable to adrenal incidentalomas? Answer: yes, hormonal evaluation is generally applicable to adrenal incidentalomas. Question: when is surgery recommended for adrenal incidentalomas? Answer: surgery is generally recommended for hormonally active tumors and those with a significant risk of malignancy. Question: how does tumor size relate to malignancy risk in adrenal masses? Answer: tumors larger than 6 centimeters have a more than 25% risk of malignancy, while adrenocortical carcinomas represent less than 2% of tumors 4 centimeters or smaller and roughly 6% of those 4 to 6 centimeters. Question: what are the criteria for tumor removal in adrenal incidentalomas? Answer: tumors 4 centimeters or larger are typically removed in low-risk surgical patients, while removal of 3 to 4 centimeter tumors is strongly considered, especially in younger patients. Question: what factors influence surgical decision-making for adrenal incidentalomas? Answer: suspicious imaging characteristics, patient's age and surgical risk, growth on interval imaging, and patient's preference influence surgical decision-making. Question: what are the characteristics of benign adrenal lesions seen on computed tomography scans? Answer: benign adrenal lesions on computed tomography scans typically have a homogeneous appearance, well-defined borders, high lipid content, rapid washout of contrast material, and a low degree of vascularity. Question: what features suggest malignancy in adrenal masses? Answer: features that suggest malignancy include irregular or ill-defined borders, necrosis, internal calcifications or hemorrhage, and high vascularity. Question: what is the role of fluorodeoxyglucose positron emission tomography scan in adrenal lesion evaluation? Answer: fluorodeoxyglucose positron emission tomography scan has high sensitivity and specificity for distinguishing between benign and malignant adrenal lesions, but cannot differentiate between metastasis and primary adrenocortical carcinoma. Question: how should adrenal incidentalomas be observed? Answer: observation involves repeated imaging in 6 to 12 months and then annually for several years, as 5% to 25% of adrenal masses may increase in size. Question: is computed tomography guided biopsy helpful for adrenal masses? Answer: computed tomography guided biopsy for adrenal masses is rarely helpful and potentially hazardous. Question: can adrenal malignancy be reliably diagnosed by cytologic criteria alone? Answer: adrenal malignancy cannot be reliably established based on cytologic criteria alone. Question: when is adrenal biopsy generally indicated? Answer: adrenal biopsy is generally limited to patients with a history of extraadrenal malignancy where a tissue diagnosis is expected to change management. Question: what must be excluded before attempting adrenal biopsy? Answer: pheochromocytoma must be excluded before attempting the procedure to prevent a potentially fatal hypertensive crisis. Question: can most adrenal incidentalomas be removed minimally invasively? Answer: most adrenal incidentalomas can be removed minimally invasively, except for those with obvious malignant features. Question: is there an upper size limit for minimally invasive removal of adrenal incidentalomas? Answer: no upper size limit has been established for minimally invasive removal, and tumors as large as 15 centimeters have been successfully removed. Question: can experienced surgeons remove large adrenal tumors using a minimally invasive approach? Answer: yes, experienced surgeons can remove large adrenal tumors using a minimally invasive approach. Metastases to the adrenal gland. Epidemiology and clinical features. Question: what is the prevalence of adrenal gland metastasis in patients with carcinomas? Answer: approximately 25% of patients with carcinomas develop adrenal involvement. Question: what percentage of adrenal metastasis cases are bilateral? Answer: in 50% of cases with adrenal metastasis, the disease is bilateral. Question: why are the adrenal glands commonly affected by metastasis? Answer: the rich vascular supply of the adrenal glands makes them commonly affected by metastasis. Question: what are the most common primary cancers that metastasize to the adrenal gland? Answer: the most common primary cancers that metastasize to the adrenal gland are lung, gastrointestinal tract, breast, kidney, pancreas, and skin cancers such as melanoma. Question: what is the significance of isolated adrenal metastases? Answer: isolated adrenal metastases represent a small subset, but resection may improve survival, especially when combined with systemic therapy. Question: who is the target audience for information about adrenal gland metastasis? Answer: the target audience is surgeons and oncologists. Clinical evaluation and surgical management. Question: what is the role of diagnostic imaging in evaluating adrenal metastases? Answer: computed tomography or magnetic resonance imaging scans are crucial for excluding extraadrenal disease, with specific protocols depending on the primary tumor type. Question: why do patients with bilateral adrenal metastases require evaluation for adrenal insufficiency? Answer: patients with bilateral adrenal metastases require assessment for adrenal insufficiency because normal adrenal tissue may be replaced by tumor. Question: how should cortical insufficiency be managed before adrenal surgery? Answer: cortical insufficiency should be treated before surgery to prevent perioperative adrenal crisis. Question: can most adrenal metastases be removed minimally invasively? Answer: most adrenal metastases are amenable to minimally invasive resection because of their well-encapsulated nature. Question: is significant fibrosis observed in metastatic adrenal disease, especially after radiation therapy? Answer: yes, significant fibrosis can be observed in metastatic adrenal disease, especially in tumors treated with radiation therapy. Question: how do survival rates differ after complete, incomplete, and no adrenal metastasectomy? Answer: complete adrenal metastasectomy can lead to a mean survival of up to 3 years, compared to 12 months for incomplete resection and 6 months for no surgical intervention. Technical aspects of adrenalectomy. Choice of operative approach. Question: what are the benefits of minimally invasive adrenalectomy? Answer: minimally invasive adrenalectomy results in decreased hospitalization length, less pain, reduced blood loss, and lower complication rates. Question: which approaches for minimally invasive adrenalectomy offer similar benefits? Answer: laparoscopic, transabdominal, and posterior retroperitonioscopic approaches offer similar benefits for minimally invasive adrenalectomy. Question: what advantage does the posterior retroperitonioscopic approach provide compared to other approaches? Answer: the posterior retroperitonioscopic approach results in reduced postoperative pain and faster recovery compared to other approaches. Question: for which cases is the retroperitonioscopic approach favored? Answer: the retroperitonioscopic approach is favored for tumors smaller than 6 centimeters, bilateral tumors, and patients with extensive prior abdominal surgery. Question: what factors can make the retroperitonioscopic approach more difficult? Answer: older age, obesity, and increased retroperitoneal fat can make the retroperitonioscopic approach more difficult. Question: which alternative approach is suitable for larger tumors and obese patients? Answer: the lateral transabdominal technique offers a wider operative field and is suitable for larger tumors and obese patients. Question: what are the indications for open adrenalectomy? Answer: open adrenalectomy is indicated for primary adrenal tumors with features suggestive of malignancy, such as large size, clinical feminization, hypersecretion of multiple steroid hormones, or imaging attributes like local or vascular invasion, regional adenopathy, and metastases. Question: what approaches can be used for open adrenalectomy? Answer: various approaches can be used in open adrenalectomy to achieve adequate exposure. Laparoscopic lateral transabdominal adrenalectomy. Patient preparation and positioning. Question: how is the operating table prepared for laparoscopic lateral transabdominal adrenalectomy? Answer: draw sheets, a full-length beanbag, and occasionally a kidney rest are placed on the operating table. Question: how is the patient positioned and prepared initially for surgery? Answer: the patient is positioned supine for anesthesia induction and urinary catheter placement, and intermittent pneumatic compression devices are applied to the legs. Question: what is used for gastric decompression during adrenalectomy, especially for left-sided lesions? Answer: an orogastric or nasogastric tube is frequently used for gastric decompression, especially for left-sided lesions. Question: what preparations are made for surgical access during adrenal operations? Answer: large bore intravenous access and blood are prepared for both right and left-sided adrenal operations. Question: how is the patient positioned for laparoscopic lateral transabdominal adrenalectomy? Answer: the patient is positioned in an 80-degree lateral decubitus position, with the side of the lesion facing upward. Question: how is the patient positioned in relation to the table for exposure? Answer: the patient is positioned with the 10th rib over the table break, buttocks and back supported, and umbilicus exposed. Question: how is the operating table adjusted during patient positioning? Answer: the table is flexed and the beanbag is rigidified to support the patient while exposing the umbilicus. Question: what is the purpose of the patient's positioning during laparoscopic adrenalectomy? Answer: this positioning widens the space between the rib cage and pelvis, lowering the iliac crest to accommodate laparoscopic instruments. Question: how is the patient restrained during surgery? Answer: white cloth tape is used to secure the patient to the table at the chest, hips, and lower extremities. Question: what precautions must be taken to protect nerves during patient positioning? Answer: care must be taken to protect bone prominences and potential peripheral nerve compression sites. Question: how is the surgical preparation area determined? Answer: the surgical preparation area extends from the nipple line to the pubis and from the umbilicus to the midline of the back, considering the possibility of open surgery conversion. Question: why is patient positioning important in laparoscopic adrenalectomy? Answer: patient positioning is essential for technical success in laparoscopic adrenalectomy. Question: how does gravity assist the surgeon during adrenalectomy? Answer: the surgeon relies on gravity for exposure, requiring extreme positioning. Question: why is secure patient fixation necessary during surgery? Answer: secure patient fixation is necessary for safe and effective patient positioning during surgery. Technique. Question: which adrenal is being discussed first in the technique section? Answer: left adrenal. Question: how is initial peritoneal access achieved for left adrenalectomy? Answer: initial peritoneal access is achieved 2 centimeters inferior to the costal margin in the midclavicular line, known as Palmer point. Question: how are trocars placed for left adrenalectomy? Answer: 4 radially dilating trocars are used, equally distributed along the costal margin. Question: where is the posterior port placed during left adrenalectomy? Answer: the posterior port is placed as far lateral posterior as allowed by the Colin's position. Question: how much spacing should be left between between ports during adrenalectomy? Answer. At least 5 centimeters should be left between ports to minimize interference. Question. What tools are used for tissue dissection during adrenalectomy? Answer. Hook monopolar cautery and an energy-based device are used for tissue dissection. Question. What surgical procedure is performed first during left adrenalectomy? Answer. The lateral attachments of the spleen are taken down first to rotate the left upper quadrant viscera anteromedially. Question. Why must care be taken when handling the spleen during adrenalectomy? Answer. Care must be taken to avoid a capsular tear of the spleen to prevent bleeding and distortion of tissue planes. Question. What is the goal of spleen mobilization in left adrenalectomy? Answer. The goal is to make the greater curvature of the stomach visible at its apex. Question. How should the spleen and tail of the pancreas be positioned during adrenalectomy? Answer. The spleen and tail of the pancreas should fall anteriorly with rightward tilting of the table. Question. Why is achieving the correct plane of dissection important during adrenalectomy? Answer. Achieving the correct plane of dissection is important to avoid injuring the tail of the pancreas and splenic vessels. Question. Where are the left adrenal gland and kidney located in relation to Gerotis fascia? Answer. The left adrenal gland and kidney are located under and posterior to Gerotis fascia. Question. Where are the spleen and pancreas located in relation to Gerotis fascia? Answer. The spleen and pancreas are located anterior to Gerotis fascia. Question. Why is dissection underneath Gerotis fascia essential during adrenalectomy? Answer. Dissection underneath Gerotis fascia is essential for locating the adrenal gland. Question. When is splenic flexure mobilization required during adrenalectomy? Answer. Splenic flexure mobilization is required for large or inferiorly positioned tumors. Question. What technique is used for splenic flexure mobilization? Answer. The open book technique is used. Dividing the splenocolic ligament. Question. What surgical plane is developed during left adrenalectomy? Answer. A cleft-like plane medial to the adrenal gland and lateral to the aorta is developed. Question. What are the contents of the left page during adrenalectomy? Answer. The left page contains the spleen, tail of the pancreas, and greater curvature of the stomach. Question. What are the contents of the right page during adrenalectomy? Answer. The right page contains the kidney and adrenal tumor. Question. What is the landmark for the left inferior phrenic vein during left adrenalectomy? Answer. The left crus of the diaphragm is the landmark for the left inferior phrenic vein. Question. Where does the left inferior phrenic vein course in relation to the adrenal gland? Answer. The left inferior phrenic vein courses along the medial aspect of the left adrenal gland before joining the left adrenal vein. Question. How is the left adrenal vein managed during adrenalectomy? Answer. The left adrenal vein is carefully dissected, coagulated or clipped, and divided at the infromedial aspect of the adrenal gland. Question. How may the inferior tip of the left adrenal gland be positioned? Answer. The inferior tip of the left adrenal gland may extend caudally, approaching the renal hilum. Question. Is it generally necessary to expose the renal vasculature during left adrenalectomy? Answer. It is generally not necessary to expose the renal vasculature during left adrenalectomy due to the length of the left adrenal vein. Question. What should be avoided during left adrenalectomy regarding the renal artery? Answer. Injury to the superior pole renal artery branch should be avoided during left adrenalectomy. Question. What imaging should be reviewed preoperatively for left adrenalectomy? Answer. Computed tomography or magnetic resonance imaging should be reviewed preoperatively to identify supernumerary and accessory renal arteries. Question. How is the adrenal gland dissected during left adrenalectomy? Answer. The adrenal gland is separated from the kidney and posterior abdominal wall to provide exposure for the procedure. Question. How is the tumor extracted during adrenalectomy? Answer. The tumor is placed into a catchment device and extracted. Question. When is tumor morcellation considered during adrenalectomy? Answer. Tumor morcellation is considered for benign tumors but never for potentially cancerous masses. Question. Which adrenal is discussed after the left adrenal in the technique section? Answer. Right adrenal. Question. How does laparoscopic right adrenalectomy compare to left adrenalectomy? Answer. Laparoscopic right adrenalectomy is similar to left adrenalectomy but mirrored. Question. What is the anatomical orientation during right adrenalectomy? Answer. The kidney and adrenal tumor are on the left, while the bare area of the liver is on the right. Question. What is the visual analogy used to describe the procedure during adrenalectomy? Answer. The procedure is likened to working on the pages of an open book. Question. What ligament of the liver must be fully mobilized during right adrenalectomy? Answer. The right triangular ligament of the liver needs to be fully mobilized. Question. How should the liver be rotated during right adrenalectomy? Answer. The liver should be rotated anteromedially. Question. Where is the colon typically positioned during right adrenalectomy? Answer. The colon is typically positioned inferior to the operative field on the right side. Question. What surgical consideration must surgeons be aware of regarding adrenal vein variations? Answer. Surgeons must be aware of adrenal vein variations when operating in the space between the adrenal gland and inferior vena cava. Question. Where can illustrations of adrenal vein variants be found? Answer. Figure 75.3 in the anatomy section provides illustrations of adrenal vein variants. Question. What are the characteristics of the right adrenal vein? Answer. The right adrenal vein is short, wide, variable, and confluent with thin walls and large capacitance, leading to potential for brisk bleeding if injured. Question. Where does the right adrenal vein commonly drain? Answer. The right adrenal vein commonly drains into the inferior vena cava, renal vein, and rarely the right hepatic vein. Question. How should surgical management proceed regarding the right adrenal vein? Answer. Surgical management should involve methodical dissection from superior to inferior, addressing potential variants and minimizing risk of injury. Question. How should the right adrenal vein be handled during surgery? Answer. The adrenal vein should be delicately dissected, definitively ligated, and then divided. Question. What should be avoided regarding the adrenal vein stump? Answer. Loss of control of the adrenal vein stump should be avoided. Question. When may conversion to an open procedure be necessary during adrenalectomy? Answer. Conversion to an open procedure may be necessary if the adrenal vein stump is lost. Question. Why is the junction of the inferior vena vena cava and right renal vein unreliable as a landmark? Answer. It is difficult to identify due to its gradual curve, making it unreliable for adrenal vein identification. Question. How is right adrenal gland mobilization performed after vein control? Answer. Right adrenal gland mobilization is generally straightforward after vein control, as the infromedial limb typically does not extend as far down as on the left side. Posterior retroperitonioscopic adrenalectomy. Question. What is the surgical technique used for posterior retroperitonioscopic adrenalectomy? Answer. The surgical technique is posterior retroperitonioscopic adrenalectomy. Question. Who popularized the posterior retroperitonioscopic adrenalectomy technique? Answer. Walls and Associates popularized it in 1994. Question. What are the advantages of the retroperitoneal approach for adrenalectomy? Answer. The retroperitoneal approach avoids mobilizing solid organs, eliminates the need for repositioning during bilateral adrenalectomy, and avoids anterior adhesions in patients with extensive prior abdominal surgery. Question. What is the main disadvantage of the retroperitoneal approach in adrenalectomy? Answer. The main disadvantage is the relatively small working space, making it best suited for tumors smaller than 7 centimeters in diameter. Question. How is the patient positioned for posterior retroperitonioscopic adrenalectomy? Answer. The patient is positioned prone with supports under the lower chest and pelvic girdle. Question. Where are the ports placed during posterior retroperitonioscopic adrenalectomy? Answer. 3 ports are placed inferior to the 12th rib using a direct cut-down technique. Question. How is the abdomen positioned during posterior retroperitonioscopic adrenalectomy? Answer. The abdomen is allowed to hang anteriorly. Question. What insufflation pressures are used in posterior retroperitonioscopic adrenalectomy? Answer. Relatively high pressures, ranging from 20 to 28 millimeters of mercury, are used without complications. Question. Where does adrenal gland mobilization begin during posterior retroperitonioscopic adrenalectomy? Answer. Mobilization begins near the crus of the diaphragm, at the infromedial aspect of the gland. Question. When is the left adrenal vein typically encountered during posterior retroperitonioscopic adrenalectomy? Answer. The left adrenal vein is almost always encountered early in the procedure. Question. How does dissection proceed during posterior retroperitonioscopic adrenalectomy? Answer. Dissection proceeds superiorly, encountering the vein slightly later. Question. How are small adrenal arteries managed during posterior retroperitonioscopic adrenalectomy? Answer. Small adrenal arteries within the medial vascular space are coagulated. Question. How does dissection progress after mobilization of the adrenal gland's superior apex? Answer. Dissection continues circumferentially, including the periadrenal fat. Complications and postoperative care. Question. What are the potential complications related to bleeding during adrenalectomy? Answer. Venous hemorrhage and bleeding from solid organ injuries are potential complications, often manageable with coagulation or direct pressure. Question. How common are hollow viscous injuries during adrenalectomy, and in which patients are they more likely to occur? Answer. Hollow viscous injuries are uncommon but may occur, particularly in patients with prior abdominal surgery. Question. What are some rare complications associated with adrenalectomy? Answer. Pancreatic injuries, fistulas, port-side hernias, and port-side metastases are rare occurrences. Question. What risk does violation of the tumor capsule pose during adrenalectomy? Answer. Violation of the tumor capsule and tumor spillage can lead to tumor recurrence, especially in cases of Pheochromocytoma. Question. Which patients are at increased risk for surgical site infections following minimally invasive adrenalectomy? Answer. Patients undergoing minimally invasive adrenalectomy for Cushing syndrome are at risk for surgical site infections due to their catabolic and immunosuppressed state. Question. What is a complication specific to the retroperitoneal approach in adrenalectomy? Answer. Injury of the subcostal nerve, causing temporary relaxation or hypoesthesia of the abdominal wall in 8% of cases, is specific to the retroperitoneal approach. Question. What is typical for postoperative recovery in patients undergoing minimally invasive adrenalectomy? Answer. Patients typically experience rapid recovery and can often be discharged from the hospital on the first postoperative day. Question. What is crucial for successful outcomes in adrenal tumor treatment? Answer. Excellent perioperative medical management and technical surgical skill are crucial, especially in cases of Pheochromocytoma and Cushing syndrome. Open anterior transabdominal adrenalectomy patient preparation and positioning. Question. What methods are used for pain management in open anterior transabdominal adrenalectomy? Answer. Pain management involves epidural catheter or local injection with liposomal bupivacaine. Question. How is the patient positioned for open anterior transabdominal adrenalectomy? Answer. The patient is positioned supine with the ipsilateral side slightly elevated. Question. How is the surgical area prepared for open anterior transabdominal adrenalectomy? Answer. The surgical area is prepared from the nipple line to the pubis and down to the table on either side. Question. What factors influence the choice of incision for open anterior transabdominal adrenalectomy? Answer. The choice of incision depends on factors such as tumor size and patient body type. Question. Which incision is preferred for thin patients with large tumors during open anterior transabdominal adrenalectomy and why? Answer. The midline incision is preferred as it offers excellent exposure while preserving the abdominal muscles. Question. Which incision is favored for patients with higher visceral fat, and what is its benefit? Answer. The subcostal incision is favored, providing better exposure for larger abdomens. Technique. Question. What side is involved in the described left adrenalectomy technique? Answer. The left adrenal is involved. Question. What is the laparoscopic approach for a left adrenal mass aimed at preserving? Answer. The laparoscopic approach aims to preserve the spleen and tail of the pancreas. Question. What challenges may arise with large left adrenal masses? Answer. Large masses may be tethered by the pancreas and spleen, increasing the risk of capsular tears. Question. What alternative approach is recommended for large left adrenal masses? Answer. Splenic flexure mobilization, lesser sac entry, division of the pancreas tail, splenic artery and vein to access the medial portion along the left diaphragmatic crus is recommended. Question. What side is involved in the described right adrenalectomy technique? Answer. The right adrenal is involved. Question. What steps are involved in open right adrenalectomy? Answer. Open right adrenalectomy involves mobilizing the liver, retracting the inferior vena cava, and entering the retroperitoneum. Question. How is the right lobe of the liver mobilized in open right adrenalectomy? Answer. The right lobe of the liver is completely mobilized. displaced, including lateral attachments and the falciform ligament. Question: how is the inferior vena cava exposed during open right adrenalectomy? Answer: the inferior vena cava is exposed by medial reflection of the duodenum after performing a Kocher maneuver. Question: which surgical plane is developed first during open right adrenalectomy? Answer: the plane between the adrenal gland and inferior vena cava is developed first. Question: how are vascular structures managed during open right adrenalectomy? Answer: vascular structures are ligated sequentially, and the adrenal vein is isolated, tied, and divided. Question: for what indications is open adrenalectomy generally performed? Answer: open adrenalectomy is generally performed for suspected or known malignant disease. Question: who is involved in managing tumors with extensive venous invasion during adrenalectomy? Answer: experienced vascular or liver surgeons are involved in managing such tumors. Question: how are locally invaded organs managed during adrenalectomy? Answer: locally invaded organs, such as the kidney, should be resected en bloc with the primary mass. Question: why is complete radical resection important in patients with malignant adrenal tumors? Answer: complete radical resection is crucial for survival in patients with malignant adrenal tumors, sometimes requiring immediate venous reconstruction. Complications and postoperative care. Question: what technical complications may occur during open anterior transabdominal adrenalectomy? Answer: technical complications include venous hemorrhage, tumor embolization, and solid organ injury. Question: how do postoperative complications following open anterior transabdominal adrenalectomy compare to those in other major abdominal procedures? Answer: postoperative complications are similar to those in other major abdominal procedures. Question: when are most patients discharged following open anterior transabdominal adrenalectomy? Answer: most patients are discharged on postoperative day 5 to 7. That's it. Thanks for tuning in. If you enjoy our content, please like, share, and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.